Hello everyone, I'm Dr. Christine Sykalo, and this is a case of gastropleural fistula following remote history of Nissen fundoplication treated conservatively. My co-authors are Drs. Al-Rubaye, Ogbuagu, and Sadka. Gastropleural fistula, also known as GPF, is a rare pathological connection between the stomach and pleural space. Most causes are related to bariatric surgery, malignancy, trauma, or gastric ulcers. Hiatal hernia can predispose to GPF development on its own. On literature review, we found no cases of direct causation of GPF by Nissen fundoplication. Pneumothorax with recurrent, unresolving empyema can be the initial presentation of GPF, which is challenging to diagnose and treat. Here, we present a case of GPF assumed to result from Nissen fundoplication 10 years ago. The case is of a 62-year-old woman with a history of GERD status post-Nissen fundoplication 17 years prior, who had recently undergone an outpatient total hip replacement. One day after discharge, she suffered sudden shortness of breath secondary to unilateral pneumothorax, diagnosed by chest x-ray when she came to the ED. A chest tube was placed, which drained thick, white-yellow pleural fluid with normal fluid triglyceride levels and exudative features secondary to polymicrobial and fungal infection. Broad-spectrum antibiotics and antifungals were initiated, and patient was admitted to the hospital. She developed recurrent pleural effusions necessitating surgical decortication through video-assisted thoracoscopic surgery, as CTA pulmonary and CT abdomen pelvis without contrast did not reveal any defects. After being restarted on a clear liquid diet, the patient was eating jello, which was noted to be coming out of her chest tube, which would explain the variable thick fluid appearance noted on admission. A CT abdomen with oral contrast showed contrast extravasation through a defect in the posterior wall of the gastric fundus, just below the post-surgical line of the Nissen fundoplication. An esophagastroduodenoscopy showed a prolapsed fundoplication into a recurrent hiatal hernia with fistula opening in the posterior aspect of the stomach's cardia. A conservative approach was implemented first, keeping patient on total parenteral nutrition and nothing by mouth with continuation of IV antibiotics. The patient's condition improved remarkably, and her scan 15 days later showed complete resolution of the GPF. The patient was then restarted on a regular diet without any further complications. In conclusion, although Nissen fundoplication is a common intervention, GPF is an extremely rare complication that can develop even many years after the procedure. GPF should be suspected in unresolving empyema with polymicrobial infections, and early CT of abdomen with oral contrast can be the initial diagnostic test to avoid surgical intervention. In reviewing the literature, we noted GPF is often treated surgically. Our case demonstrates conservative management can be curative and may be used as an initial approach in stable patients. Timing of repeat imaging is case-dependent, as some cases that we read showed lack of resolution after months of conservative therapy. Treatment should be based on a shared decision with the patient, as conservative therapy, while non-invasive, may be prolonged and limit the patient's lifestyle. Thank you for listening.